Doctor, we are live now.
Hello and welcome everyone for this journal club, the live journal club by Glaucoma Society of India. Today we have Dr. Rajul Parikh talking to us on the sensitivity, specificity, and the predictive values. He is the director of the Parikh's Glaucoma Care Center from Mumbai. Then we have a presentation by Dr. Hasini. She is a fellow at Arvind Hospital, Chennai. She is going to present the topic on slow coagulation, transscleral cyclophotocoagulation in pseudoexfoliation glaucoma. And we have her mentor, Dr. M.B. Madhuri. She is a senior consultant at Arvind Hospital in the glaucoma department, Chennai. Then we have two wonderful panelists. Dr. Bhaskaran Mani from Director, Glaucoma Services, Sankunetralaya, Chennai. And we have Dr. Devendra Maheshwari. He is a senior medical consultant at Arvind Hospital, Tirunelveli. So without much delay, we will be starting the first talk by Dr. Rajul. And just to give the information, we have completed the presidential masterclass. All the talks have been completed. If someone wants to see those master classes, please log into our Glaucoma Society of India website and you can see that lectures. It's available in the YouTube. I think we have sent to all the GSI members and also the AIOS members. And we would like to inform you that for the GSI, there is active registrations are going on. Those who have submitted all the abstracts are getting reviewed, and soon you will all receive the information. I wish everybody registers quickly so that there's no issues on the accommodation of the rooms and other things. So thank you one and all for joining for today's live webinar by Glaucoma Society of India for the Journal Club. Over to you, Rajul. Rajul? Rajul, you are able to hear me? Yes, looks Rajul is in.
Can you hear me?
Rajul?
Yes, we can.
Yeah, so there's some issue with my network.
Okay, can we have Dr. Hasini do her first presentation and then you can get in?
So I'm there.
Dr. Hasini, can you just open up your talk?
Can you hear me now?
Yeah, we can hear you. Dr. Hasini, you can just share your slide. Dr. Hasini? Why is Rajul and Hasini, both of them? Madhuri,
Yes, sir.
can you just find out what's the difficulty?
Yes, sir, sure.
Can we both also cut the video and then
Yeah.
see if the network is getting better?
Yes, sir, sure.
Rajul also has the difficulty.
Hello.
Yeah.
Hello, Hasini. Can
Yes,
you
Dr. Hasini. Yeah.
share the video, Hasini?
Share your slides, please.
So do I need to share my slides?
Yes, yes. Please share your slide. Dr. Hasni, can you? Yeah. You can share your first slide and then, yeah.
Can I start my presentation, sir?
Yes, please.
A warm welcome to everyone present. Can you hear me, sir? Am I audible?
Yes, doctor, go ahead. Go ahead. Your presentation is seen and you are audible as well. Dr. Hasani, we can hear you. We can see your slide. Please go ahead with your presentation.
A warm welcome to everyone present here. I'm Dr. Hasani, Glaucoma Fellow from Aravind Eye Hospital, Chennai. First and foremost, I would like to thank Dr. Sharmila ma'am, Dr. Neetu ma'am, and Dr. Madhuri ma'am for giving me this opportunity to present in this esteemed platform. I'd like to begin with a short introduction. Pseudoexfoliation characterized by abnormal deposition of extracellular fibrinolysyl oxidase like 1 gene. This gene is essential for elastin metabolism. The dysregulation of this gene may lead to structural abnormalities in the lamina cribrosa of pseudoexfoliation patients. The pseudoexfoliation glaucoma is mainly caused by three main mechanisms. One is obstruction to the trabecular and uveoscleral outflow pathway by the deposition of exfoliative material. Second is by possible structural abnormalities in the lamina cribrosa due to defective elastin metabolism. And third, it can also cause a form of secondary angle closure glaucoma due to zonal of weakness leading to lens subluxation. The treatment of pseudoexfoliation glaucoma is challenging because it has higher baseline IOPs, there are greater IOP fluctuations, there is poor response to medical therapy. Hence, these patients require early surgical interventions. Traditionally, continuous wave transcleral cytophotocoagulation was used in end-stage glaucoma as a pain-relieving procedure. It effectively reduces IOP by decreasing the aqueous humor production through coagulative necrosis of the ciliary body. It uses high energy, 1750 to 2000 milliwatt over short duration, that is 2 seconds, which causes explosive tissue damage, often indicated by audible pops. Laser delivered at a continuous dose frequently results in significant collateral tissue damage, thus contributing to severe vision-threatening complications such as hypertony, phthisis, cystoid macular edema, uveitis, and sympathetic ophthalmia. We then had micropulse transcleral cytophotocoagulation. In micropulse, it delivers energy in short repetitive pulses followed by pauses, which allows for a cooling period, thereby potentially reducing the risk of damage to surrounding tissue. However, since we use a single-use probe, it is either expensive or logistically challenging. There is also lack of standardization. For example, there is no consensus on sweeping velocity. To improve the safety profile while maintaining efficacy, slow coagulation transcleral cyclophotocoagulation was introduced. This uses lower laser power, that is of 1250 milliwatt, for a longer exposure time, that is 4 seconds per spot. It results in controlled tissue coagulation, less inflammation, and decrease in complications comparatively. Coming to the article per se. This article is titled Slow Coagulation Transcleral Cyclophotocoagulation. It is published by Mohammed M. K. et al. In Journal of Glaucoma in April 2025. The research question was, is slow coagulation transcleral cyclophotocoagulation effective and safe in the management of pseudoexfoliation glaucoma? It was a retrospective observational non-comparative study carried out in a single center, Bascom Palmer Eye Institute in Miami, Florida. The patients with medically uncontrolled pseudoexfoliation glaucoma between the period of 2018 to 2022 who underwent slow coagulation were included in the study. The other inclusion criteria were pseudoexfoliation glaucoma patients aged 18 years and above. Patients with prior history of glaucoma surgery were also included. In cases that underwent bilateral transscleral cyclophotocoagulation, only one eye was randomized to analysis. Patients with no light perception or with less than 6 months of follow-up were excluded from the study. 5 glaucoma surgeons performed the slow coagulation treatment using the G probe. The power setting was 1250 milliwatt. Duration was for 4 seconds. Patients received 16 to 22 laser applications during treatment. The number of laser applications was determined at an individual level based on the severity of glaucoma, visual acuity, number of ocular hypertensive medications, and current IOP in relation to target IOP. The total energy applied during transscleral session was calculated using the below equation. Total energy is equal to power into time into number of spots. Coming to the outcomes. The primary outcome measure was the cumulative rate of surgical success after single and multiple treatment sessions of slow coagulation transscleral cytophotocoagulation at 12 and 24 months. Success rate was defined as IOP between 6 to 21 millimeters of mercury or with more than 20% reduction in IOP from baseline on 2 consecutive follow-up. Those patients that developed loss of light perception or those who required reoperation for glaucoma were considered as failure. The qualified success was defined as success with additional glaucoma medications, while complete success was defined as success without additional glaucoma medication. The secondary outcomes that were measured were IOP, glaucoma medication numbers, visual acuity, and postoperative complications. Coming to the methodology, for all enrolled patients, the following data were studied: clinical characteristics, preoperative and postoperative IOP, glaucoma medication and postoperative complications at one applanation tonometer was used to measure the IOP. The postoperative complications that were studied were anterior chamber inflammation, which was defined as any degree of cells noted on slit lamp examination, hypertony, which was defined as IOP less than 5 millimeters of mercury on 2 consecutive visits, together with clinical signs of hypertony such as macular folds, loss of light perception vision, cystoid macular edema, prolonged postoperative pain, and pupillary abnormalities. Statistical package for social sciences version 29 was used to perform statistical analysis with probability values of less than 0.05 considered statistically significant. Snellen difference between preoperative and postoperative visual acuity, IOP, and glaucoma medication were evaluated using a paired t-test. Kaplan-Meier estimates of survival to the treatment failure endpoint were constructed after a single slow coagulation treatment and after more than one slow coagulation treatment. Coming to the results. The baseline characteristics of this study was as follows. The total number of eyes included in the study was 48. The median age was 87.5 years, which is more an elderly cohort. 58.3% of them were females, while 41.7% were males. They were predominantly non-Hispanic white. All eyes, that is 48 of them, were pseudophakic. The number of eyes that went prior surgical IOP lowering treatment was 32. Coming to the success after single slow coagulation, the qualified success after single slow coagulation was 47.9% at 24 months, and complete success was 33.3% at 24 months. 14.6%, that is 7 eyes, had more than one session of slow coagulation treatment. The qualified success at 2 years was 56.2%, and the complete success at 2 years was 39.6%. Coming to the IOP, the baseline mean IOP was 29.6 plus or minus 10.3 millimeters of mercury. There was consistent reduction in IOP across all follow points, with the final IOP at 2 years being 13.8 plus or minus 5.1 millimeters of mercury. 89.6%, that is 44 eyes, had more than 20% reduction in IOP from baseline. Mean glaucoma medications reduced from 3.7 to 2.6 on average. Significant reduction across all follow-up points was noted. At the last follow-up visit, the mean number of glaucoma medications decreased by 1.1 from baseline. The visual acuity decreased from logMAR 0.85 to 1.24, that is about from 638 to 6 by 96. 18.8%, that is 9 eyes, had 2 or more lines decrease of Snellen visual acuity. 4.2%, that is 2 eyes, had loss of light perception. However, it is noteworthy to mention that the pre-op visual acuity was light perception. The most common cause for reduced visual acuity was glaucoma progression, followed by cystoid macular edema. Coming to the complications, 5 eyes, that is 10.4%, had iridocyclitis, which was transient and reduced with topical steroids. 5 eyes, 10.5%, had hyphema, which resolved with conservative management. 2 eyes, 4.2%, had cystoid macular edema. However, both these patients were diabetics and they had also undergone prior cataract extraction. 2 eyes had hypertony, which was transient and resolved with topical steroids and atropine. No cases of prolonged postoperative pain, retinal detachment, mydriasis, or phthisis was reported. To sum up, the surgical success after single slow coagulation transcleidal cyclophotocoagulation treatment was qualified success was 47.9% at 2 years and complete success was 33.3% at 2 years. After more than one session of slow coagulation, the qualified success was 56.2% at 2 years, while the complete success was 39.6% at 2 years. The intraocular pressure, 90% of the patient reduced. 90% of the patient had decrease in had more than 20% decrease in IOP from the baseline. There was average reduction of 1.1 glaucoma medication. The visual acuity slightly worsened. 14.6%, that is 7 eyes, required more than one session of slow coagulation. Overall, the complications were minimal and transient. Coming to the discussion, in slow coagulation, by reducing the energy power and by not waiting for the audible pop sound, which represents over-treatment and explosive ablation of ciliary body, there is less tissue destruction and inflammation. In addition to its effectiveness and relative safety, slow coagulation can be advantageous in patients who are poor candidates for incisional or angle-based surgeries. It is also titrable and conjunctiva sparing, so it can be repeated and does not interfere with future incisional treatment options. It has a short post-operative recovery period. Coming to the SWOT analysis, these were the strength of the study. It was the first study to look at long-term outcomes in pseudo-exfoliation glaucoma. There was sustained reduction in IOP. Though it was a retrospective study with a small cohort, the efficacy is comparable to that of continuous wave and micropulse based on previous trials. There was minimal procedure-related complications, minimal vision-threatening complications. Coming to the weakness, it was a retrospective observational study, no control group, small study population. It was an elderly cohort, predominantly non-Hispanic white was the race. I don't know whether the results can be extrapolated into the Indian eyes. Number of eyes that underwent prior surgical intervention was 32. However, documentation for only 22 eyes is available. The baseline visual field test is unavailable. There was decline in visual acuity despite improvement in IOP control. Coming to the opportunities, it opens the door for further prospective trials and head-to-head comparison with continuous wave and multipulse transcleidal cyclophotocoagulation. We can study the role of slow coagulation in other causes of refractory glaucoma. It is cost-effective and can be feasible in low and middle-income countries. Threats would be minimally invasive glaucoma surgeries. Without high level of evidence at present, its adoptability based on current article may be questionable. When I did a literature search, I came across these 3 articles. The first 2 articles was published by the same author. The first article is published in the Journal of Glaucoma. It looked at the role of slow coagulation in patients with silicone oil-induced glaucoma post-pars plana vitrectomy. The mean IOP reduction was about 50% and success rate at the end of 1 year was 72%. The second study was published by the same author in British Journal of Ophthalmology in 2023. It looked at the role of slow coagulation in medically refractive neovascular glaucoma. There was mean IOP reduction of 50%, and the success rate was about 71% at the end of 1 year and 64% at the end of 2 years. The third study was carried out in Indonesia, where they compared the role of, where there was comparison between slow coagulation and multiple transscleral cyclophotocoagulation. The IOP reduction was slightly higher with slow coagulation at 45% and micropulse was around 35%. The rate of hypotony was slightly more with slow coagulation while compared to multipulse. To conclude, in medically uncontrolled pseudoexfoliation glaucoma patients with good visual potential, slow coagulation is a promising option based on its efficacy and safety profile. It can also be used as a temporizing measure prior to incisional surgery. However, patient selection is crucial as the results cannot be generalized. Thank you.
Thank you, Dr. Hasani, for a wonderful presentation. May I request the mentor, Dr. Madhuri, to give her comments, and then we'll move on with the panel discussion.
Sir, in this particular study, actually, the slow coagulation is supposed to have less inflammation and less chances of hypertony. But the rate of inflammation is around 10%. And also the 2 eyes had CME, which is nearly 4%. And also 2 eyes had hypotony. So how do you actually grade the safety of this slow coagulation?
Dr.
Actually,
Hasani, can you just unshare, close
Yes,
your
sir.
presentation so that we can see everyone? Yes. Yeah. Yes, Madhuri, please.
Sir, that's what, sir. Actually, slow coagulation is done so that there is less inflammation, there is less complications like hypertony and CME. But in this particular study, almost 10% had iridocyclitis and 4% had, that is, 2 eyes had CME, 2 eyes had hypotony. So, how do you rate that this is a safe procedure? Another thing is, when you calculate the total amount of energy that is delivered in these patients, actually it is much higher when compared to the conventional diode. The total energy that is delivered in these eyes are actually much higher because of the longer duration. When we multiply and then when we see, then the total so that it's delivered for a longer time, though the power is very less. So the complication rate is much less. So it's relatively safer, but I wouldn't say that it is completely safe.
All right. Okay. So, do you do in your center?
So I personally don't do, but there are few consultants who do. And another thing I want to say is, so probably in those Western studies, actually the probe that is used is only one-time probe. But what we do here is we reuse the probe. We ETO the probe and then reuse it at least 5 times. So in case of these slow coagulation, we don't know the endpoint also. At least in the conventional diode coagulation, we know the endpoint is pop and then we reduce. Once we hear the pop, we can, titrate the power. But in this, we just have to look for the blanching, slight blanching or some slight changes which are happening. So how far, if we do it in our setup, I really don't know whether we will be able to assess whether that probe is working, not working. How do we go about it? And the same author has written two other articles where silicon oil glaucoma, as well as in neovascular glaucoma, he shows that the rate of inflammation is almost 10% again. And also the chances of hypotony and CME are present. So maybe the relative risk is little less, but I think the risk stays.
All right. Okay. Let's hear from our panel, and then we can have a further discussion. Bhaskar and Devendra.
Okay.
Yeah, Bhaskar.
So there are quite a number of points that raise from this particular study. The authors have done 2 studies, silicon oil as well as the neovascular glaucoma. The IOP control there at 70% at 1 year could be because of other factors also. When they remove the silicone oil or steroid and NVG, when they do the lasers, the IOP control become better. So it's not possible to judge the efficacy in such eyes. Pseudo-exfoliation glaucoma, yes, you can judge the efficacy of the procedure. Now, I also have a question to the other panelists and other consultants here. How many of you hear a pop at 1250 milliwatts in a new probe, 1250 milliwatts? I hear it. Many of the cases. We also ETO it and use it for 5 cases at the most. And we do hear it at 1250 milliwatts itself. And if you're going to hear a pop at that, and then if you're going to continue at the same power for 4 seconds, it's going to be a problem also. So that is one thing about the safety part of it. You need to titrate below that 1250 also sometimes. So I'm not sure, the authors have not commented about it. And obviously it's a retrospective study, there may be issues. And we don't know, the inclusion criteria is a bit vague. It says pseudo-exfoliation glaucoma, but they have not really said whether it is like, very, poor vision patients only are included. But when you are looking at the range of visual acuity, also they have not given the visual acuity range in all the situations, all the time periods. So there are lots of missing things in this. The reviewers have probably missed out on all these things. And again, how many were excluded? That they have not mentioned. In that study period, they have included only 48 eyes of 48 patients. But how many they have done actually in pseudo-exfoliation glaucoma? That will give us an idea as to how many they have not included and how many of them had, issues with safety and all. We can think about it, because if the percentage of inclusion is less than 70%, then the study may not have that much of value. And again, single versus multiple treatment also, they have included for success. They have separated out, but they have not given the follow-up range. If you actually look at the range, 1 year is the minimum. But how many of them actually went through 2 years for them to give this Kaplan-Meier curve? So that is another issue. But whatever patients they have included, they have shown a drop in IOP, but you can see that the glaucoma medications, again, mean glaucoma medications came back to 2.6 from 3.7. So that tells us that the patients required medications again. That is one more thing. And I think obviously this is an elderly cohort, and we know that younger patients may have lesser success as well. From all our studies, we know that. And again, the visual acuity has decreased. So that is something of a concern. So overall, I think they have overestimated the success and also the safety. So that is something which I am concerned. And obviously, the PRECI tells everything that you require more studies to decide about this. So, and again, I'm concerned about that 4-second period. So even the dosage as well as the time period needs to be titrated before we can accept this as a relevant procedure in the first place. And this is what I can tell. I think there are other people who can give more thought process on this, Dr. Devendra as well. Yeah.
So I think most of the money you have covered, but regarding the Madhvi's concern regarding the inflammation, I think inflammation is not big issue about this study at the 10% or 15% may do the diode laser. And if we compare, because we are doing since 12 years, so previously we slowly starting the slow mode, that longer duration. So we feel the rate of hypertony, rate of complication is much, much lesser in the slow mode in compared to the higher power and the short duration. So the Gunderson criteria that has the more complications. The new method is really take time to work. It not if a reduced IP much in compared to the older version, but really it works. So what we can do, what we can understand from this study, even the slow coagulation is going to helpful, especially when you having the useful vision. So such eyes you can try and you can wait for some time. So just comprising is one good way. Instead of older method, what we used to do just for the very poor visual eyes. That's my intake from this. Apart from that, recently we doing the lot of me and my colleagues at Madurai, when we have the acute situation, high IOP, especially chronic glaucoma, we do first slow coagulation. and then after some time, we do the phacoemulsification. So I think these are you can understand these can give by some time. And again, one more point about that repeat DLCP. I'm little bit I think authors didn't look for long-term outcome. When we look for the retrospectively our patient, we repeat the DLCP. Down the line, 5 years, 6 years, 7 years, we got the chronic hypertrophy, even the some case thysis also. So repeating DLCP, we will be very, very cautious. That message I don't want to get from this article, why they repeat so fast.
Yes,
Because,
7 eyes were repeated, sir. Actually,
yeah,
seven
yeah.
eyes had undergone within 1 year.
Yeah, if you
Repeat.
look for the literature, we don't have any literature which follow up more than 5 years. They're saying that for longest follow up 5 years, but you see the mean follow up period, it come around the 48 months and 36 months only. So these things we have to keep in mind when we take the such eyes for the DLCP.
Rajul?
So, as Bhaskar was talking about, when the retrospective study itself, when it comes, now we have to look the data very carefully and with lots of suspicion, because and Bhaskar pointed out, that how many patient excluded is not mentioned. So most of the time, and lots of time, this is the bias. So you include only the patients who have a positive results. So retrospective study always has limitation, especially when they are not clear in their inclusion exclusion criteria. And my bottom line question is that in a seeing eye, in neovascular glaucoma, in some time, or in a when eyes in multiple surgeries were doing standard surgery is an issue. In a seeing eye, why to do destructive procedure? So I don't think that we should send a message about, and when Devendra said about acute angle closure, there is a different case scenarios. But in general, why to promote destructive procedure as a primary modality? Because I think that should be kept as a little bit as a later part. This study, I when I read it, and I felt that it didn't give any additional information which was already available in literature. If you look archives way back in 2002, the regular TSAPC, not the slow, they had 20% or 30%, at least two line vision loss. They had CME, and that article also was written with the perspective that the trap should be removed, and the cyclophotocoagulation should be the first line treatment in all POAG patients. They also had the same issue, lots of bias. So, and this article also, I felt that it was written with lots of bias about promoting destructive procedure as a first line. Uh, so, retrospective, most of the time I don't give any value to retrospective study unless it's really nicely done with proper mentioning sample size calculation, or mentioning at the end the power of study, proper inclusion exclusion criteria. If that is missing, whether it's published in any journal, I would not give much weightage in changing my practice.
Dr. Hasni, can you just give a few of the answers, like why was it the procedure chosen as the first procedure? Is there
So
anything mentioned in the article?
it wasn't chosen as the first procedure, sir. In fact, some of the eyes had already undergone previous glaucoma surgery. So they not mentioned that slow coagulation was the first line of treatment. They just wanted to study
Is it that only some patients
Some
who,
patients,
is it that some
so
patients
some
have
patient held
done,
as a primary procedure.
So almost
At 22 eyes only had a previous glaucoma surgery done already. All the eyes were pseudophakic. The rest of the 16 eyes were actually only cataract surgery was done. They were actually virgin eyes.
no, almost
Virgin window.
60% of the eyes they had it as the first procedure.
yeah.
So if you
Yeah,
actually look
16.
into it, so they
Yeah,
Yeah,
have,
the
16
data
eyes.
shows that, yeah. Can you just share the, Rajul, is it your presentation is there, or?
Yes, it's ready. I can.
Okay. Once your presentation is there, then we'll just, after another 5 more minutes,
Yeah.
then we'll have our 6 minutes then we'll have your presentation for next 20 minutes.
My network is working okay at this point in time. So we'll
Right.
start.
Sir, do you have anyone has any idea about the slow versus routine DLCP? Did we encounter any kind of study such as this? Anybody?
One of
We
our
use
PGs,
micropulse, Devendra, so I don't
Hasni.
have any experience with that. Yeah.
One of our
No, I
PGs
don't
had
think
a
so.
thesis on that, sir. Hasni will just tell you this thing, sir.
So,
Hasni,
we,
can you share that?
so I don't have slides of it, but then we
Yeah,
did
that's okay. Yeah.
Yeah. So we did a prospective study comparing the continuous wave and slow coagulation, sir. So totally 31 eyes were included in the study. 18 eyes were in the group 1, which is continuous wave group, and 13 eyes were in the slow coagulation. The median age in continuous wave was 56 years, while the median age in slow coagulation was around 61 years. The IOP reduction in continuous wave was from 49 millimeters of mercury to 22, while in slow coagulation, it reduced from 48 millimeters of mercury to 21. They followed up in one post-op 1 month and post-op 3 month. AGM reduced from 3.17 to 1.78 in continuous wave, while in slow coagulation, it reduced from 3.23 to 2.38. So basically, there was less than 30% of IOP reduction from baseline in both groups, sir. Continuous wave, it was around 100%, while in slow coagulation, it was roughly around 92%. What was interesting to find was that when it came to complication, the rate of anterior chamber inflammation was more in conventional, while there was significant increase in conjunctival burn when compared to slow coagulation. So in slow coagulation, there was more conjunctival burns.
All right. Okay.
So what our experience is that if you go for the slow, even the IP control is much less in compared to the continuous wave. But in long term side effect are much lesser. Though I don't have the data, like the retrospective, I pull out my retrospective data. That's our experience. So continuous wave really have the more complication long term. The slow mode has the really less complication. But again, we have to buy the another thing. We don't have that much IP control that we get with the continuous wave.
Okay. So can we just give the audience a message saying that in pseudo exfoliation glaucoma, as a routine like a primary opening glaucoma, it is always the medication first, and then probably some cases maybe SLT to an extent. And the trabeculectomy, if you are going to choose as the first procedure, trabeculectomy will be the first choice. And then in few patients, wherever you feel it is appropriate, then you may select the cyclophotocoagulation. But then for me, again, there is a role of micropulse has definitely a role to play in this, because that is much more safer than the regular TSCPC and also the slow coagulation, the so-called slow coagulation. So can we just give that
Just
message to
Yes.
take home?
Sir, sir,
Yes, please.
before trabeculectomy, we can try MIGS. MIGS
Sorry. Yeah. You are an MIGS guy, so
yeah,
definitely MIGS has its own.
Devendra, MIGS, but not in all cases.
Yes.
MIGS in selected cases. If
there
it is
is
advanced glaucoma, I would not consider MIGS.
no. I'm talking about pseudo exposure.
So we can discuss that in MIGS in pseudo exfoliation very elaborate. Definitely, yes. But of course, I just forgot to mention that because not routine. So once upon a time, it was not routine. Now it has become like that. So it has become a routine now in the majority of the institutions now. So we'll have that as definitely an option before we go for this TSCPC or micropulse. Definitely, yes. So thank you so much for the wonderful presentation, Dr. Hasni, and the mentor and the panel. And may I request Dr. Rajul to give his presentation on the sensitivity specificity. Over to you, Rajul.
Okay, thank you. So, I'll be talking about sensitivity, specificity, predictive values, and if time permits, likelihood ratio. Now, when we do a diagnostic test, there are two things. One is reliability of the test, and I'm not going to cover that part. I'm going to cover the second part, whether the test is valid and how to use in day-to-day clinical practice. And this is very relevant because we use all the machines OCT, perimetry, various imaging, in even IOP, that what is the diagnostic accuracy of this test in clinical practice. And for that, we have two parameters, sensitivity, specificity. Predictive values are calculated based on sensitivity, specificity, and prevalence. So I'll try to cover that part in detail. So we have 2x2 table. Once you know this 2x2 table, you can do calculate all this diagnostic accuracy of the various tests very easily. On the vertical, basically we have a gold standard and we have a new test. So gold standard detects the disease. Now we are not going to cover the debate versus gold standard and new test, but when the new test, we have, this is a disease population. If the disease is picked up by the new test, this is true positive. The disease is missed by the new test is false negative. And this vertical column put together is total disease population. On other side, where the disease is not there, patient is normal, and the disease, the new test is labeled, the test is the patient is normal, that is true negative, and the test is falsely labeled the disease as present, that is false positive. So this is normal population. Now, A plus C is a disease population and B plus D is a normal population, and A plus B plus C plus D is a total population, or what we have taken for the study. The prevalence is A plus C divided by A plus B plus CD, that is the prevalence of disease. So if you have a 10 patients here, 10 and 900 here, that means prevalence of disease is 1%. Sensitivity is A divided by A plus C. So this is true positive divided by true positive plus false negative, that is sensitivity, and specificity is the true negative divided by true negative plus false positive. So that is specificity. D divided by B plus D. Now, basically, sensitivity is ability to identify the disease, and specificity, ability of the test to identify normal as normal. And predictive value is, if the person is positive on a particular test, what is the probability that the person actually has the disease we are targeting for, looking for? That is positive predictive value. And for the normal, if the machine, the test label patient is actually not having disease, that is negative predictive value. So again, true positive divided by true positive plus false positive, that is positive predictive value, A divided by A plus B. And TN, true negative divided by true negative plus false negative, it is the negative predictive value. Now, these are the four things we will cover in first half. Now, let's say that we have a test. We have taken 100 people in the disease and 100 people in normal population. So, our population is 200. The prevalence of the disease is 50% because we have 100 normal, 100 disease. Now, this test has picked up 90% as disease and 10% he has missed. So, the sensitivity is 90%. He has picked up 80 people as normal, whereas 20 people he has marked flagged as abnormal. So specificity is 80%. Now this is one information. Now how the prevalence of the disease changing the scenario. So here positive predictive value is 90 divided by 110, that is 82%. That means at 50% of the prevalence, if the test is positive, you are very sure that patient has a disease because it's more than 80%. But this is not the real life scenario. You cannot have 50% disease population in a general population. So let's say I have changed the prevalence. Now I have 90, 100 and 900 normal. That means 10%. Sensitivity specificity remains same. But predictive value now is reduced 90 divided by 270, that is 33%. Negative predictive value is increased to 98.6%. So now as the prevalence reduced, the positive predictive value as test is reduced drastically from 82% to 33%. These again is not real life. 10% disease population in general population is not the norm. 1%. Sensitivity specificity test remains same. The predictive value is reduced now to 4% and 99.8%. So the information is that the sensitivity specificity of test remains the same all the time, but the prevalence of disease reduced So the predictive value has gone down. So if you use the information what I want to pass on, that when we do a test in a general population, we have to remember that what is the prevalence of disease, which is usually a very low. So unless you are identifying the high risk group and doing the test, you are not going to get the good yield of the any test. So in a real life, the disease is a small group compared to the normal population. And that's why the predictive value plays a big role. If you know what we are doing it and why we are getting a lots of false positive. So predictive value already defined. And the second thing you must remember, as the prevalence increases, the positive predictive value increases. Because now we have more and more disease population, there are very few normal. So if a sensitivity is 90%, we will pick up majority of the disease because the prevalence is very high. But I'm give two examples, glaucoma and diabetic retinopathy. Both the test has a prevalence of less than 5%, 3%, 4%. If you're 3-4%, then what you will get if you do randomly in 100 people of normal population where there are 3 or 4 glaucoma, the positive predictive value is going to be 5% for a test which has a 90% sensitivity and 80% specificity. Okay. The negative predictive value is not important. I will not elaborate much, but basically, if you don't do the test, you are 98% or 96% sure to start with. So why to do the test? So if you are clinically not suspecting a glaucoma, then there is no need to do any test to calculate negative predictive value because you can never be 100% sure. From 97%, you can go to 99%. I'll just give example. From 97% to 99.5%, but you are not 100%. And anyway, 97% you were sure to start with that there is no test. So negative predictive value is not important from day-to-day clinical practice. Now, there are certain things you must remember. What is the importance of sensitivity and specificity? So the mnemonics is spin. Any highly specific test, if positive, rules in the disease. Now it sounds very contradictory that I'm talking about specificity and ruling in the disease. I'm not talking about sensitivity. And why? Because let's say that if your test is a 98, 99% specificity, that means it's going to make sure it is not going to put any false positive. So 99% of the patient, it is going to label normal as normal. So what left over is a disease population. So any highly specific test, if positive, rules in the disease. And snout, any highly sensitive test, let's say the test is a 99, 98% of the sensitivity to detect glaucoma. If it's negative, then you are very sure that it rules out the disease because 99% it would have picked up. So this is how you use the sensitivity specificity of the test in day-to-day practice. Now, limitation. So this is very perfect. Sensitivity specificity is very good concept-wise, but there are always every test is a limitation. So what happens that in a 2x2 table, we always label disease, not having disease. But the disease has a different grade. So whether it's early, if the test has early glaucoma, moderate glaucoma, mild glaucoma, on top of it, there is a gray area. So like glaucoma suspect, the large D. So there are lots of variability involved, and this you have to look into that what authors have tried to evaluate which cases they have taken. So if I take glaucoma suspect and I define properly, then I can use this data in my glaucoma suspect category. Otherwise, no. And second, the sensitivity specificity is considered independent of prevalence. But as I mentioned in my previous slide, the disease severity. So if I am looking perimetry in advanced glaucoma versus early glaucoma, my sensitivity specificity is going to be very good for advanced glaucoma as opposed to early glaucoma where the perimetry may miss out the glaucoma. So this is how you must understand the limitation of these two tests. Now I will, Satyan, we have some time now.
Yes,
So
Rajul, please.
so I will try to cover likelihood ratio, which is very important. The likelihood ratio, and we started writing in our article way back. I was in residency, and now the most of the good journals, they made mandatory that when you report diagnostic test, you have to mention likelihood ratio, because it allows the base apply the results to clinical examination testing into individual patient. Now we are talking about individual patient, one patient at a time. So what is likelihood ratio? That is likelihood that given a test result would be expected in a patient with a target disorder compared to the likelihood that same result would be expected in a patient without target disorder. So I would positive likelihood ratio, probability of individual with the condition having positive test divided by probability of individual without the condition having a positive test. You don't able to calculate because now, because the journals are very strict, most of the author would write down likelihood ratio of their test in their article itself. But for your understanding, sensitivity minus 1 divided by 1 minus specificity is positive likelihood ratio, and 1 minus sensitivity divided by specificity is negative likelihood ratio. Now, there are certain, these four things you should know. Pre-test probability. Now, what is pre-test probability? Basically, it's prevalence of disease. So, if your glaucoma prevalence is 2%, in your population, you can use 2%, or you can take the data from the published articles that Vellore Eye Survey, Andhra Pradesh Eye Survey, Arvind Eye Survey. So, all the different that what glaucoma or Chennai, that what glaucoma percentage they have taken, and I will use that data. Now, pre-test probability converted into pre-test odds. That is pre-test probability divided by 1 minus pre-test probability. So that is pre-test odds. Now, pre-test odds is multiplied into likelihood ratio. That gives post-test odds. And this is converted into a probability. Post-test odds divided by 1 plus post-test odds. Now, this is a post-test probability. So if once we calculate this, we get that after using this clinical examination, test, imaging, perimetry, whatsoever, what are the chances that my patient has glaucoma? So let's give one example. So basically it incorporates the prevalence of disease, patient pool, specific patient risk, because now you have checked patient's IOP, you've done gonioscopy, you've done patient's perimetry, imaging, and you use all the data in your patient to calculate what is the likelihood that patient has a glaucoma. So let's say this is the example, 45-year-old male patient, family history nil, open angle, 24 millimeter mercury, optic distortion 0.7 coverage ratio, inferior rim thinning with wedge-shaped RNFL defect. Perimetry is normal, and I've used GDX. This is our published data that and NFI index more than high, the 59, more than 50. This is what we will use. Now, this is the data. IOP at 25 cutoff body, this is sensitive specificity. I've used again all the published data I've used that what is the sensitive specificity. And this is the likelihood ratio calculated 6.25 for IOP, 16 for optic disc, and 55 for GDX. So I have used prevalence as given population, and it is 0.05. I have used the Vellore data. I now use my first test, that is IOP, because that is the first test we use. And based on that, it is now 0.24. So you must convert into the percentage. Once you check IOP, if it is more than 21, the chances of patient having glaucoma is increased from 1% to 24%. Not good enough for the glaucoma diagnosis. Now I use my optic disc second. So I again converted to pre-test odds, multiply, converted to post-test probability. It is now 84. So based only on my IOP and optic disc, now I'm 85% sure that this patient is glaucoma, which is good enough to start treatment. But I want more. So I use my GDX finding, and now is 0.997. That is 99.7%. So this is how I used my all clinical examination to make sure that what is the chances of this patient having glaucoma. So, and you can do in one test also, the result would be same only. And you can also use this nomogram available from pre-test probability to the post-test probability. So you don't have to calculate, don't have to do all these maths which I just showed. But the bottom line is that how to use, when to do this calculation. In general, every patient would not require. So the general guideline, if you look from the epidemiological perspective, clinical epidemiology, if you are on left side, that is clinically you are not suspecting glaucoma, your threshold, you are saying that the chance is not even 20%, do not test. And why do not test? Because in this pre-test probability, even if your results are positive, you will come in this gray area where your test would give you more confusion than the solution. If you are more than 80% sure, that means if the patient is a 0.85 coverage ratio with inferior notch, with definite weight shape decay, with pressure of more than 21, that means I am very sure that patient has glaucoma. I am not doing test to diagnose the patient, but I am doing test for the monitoring. And here, when you are in doubt, this is the gray area when if you do the test, you will go into the left side or right side of the zone. That means you will know that patient has glaucoma or patient doesn't have glaucoma. And this is how you should use the diagnostic test like sensitivity, specificity, predictive value, and likelihood ratio. Likelihood ratio is very important from day-to-day practice. Predictive value is more important from the screening point of view. And of course, every test would require sensitivity specificity. So that itself is not important, but you can use spleen and snout for your individual patient. So Satyan, I think I didn't overshoot the time. I finished well in reasonable time limit.
Thank you so much. Thank you so much, Rajul. And it is such an important presentation. And I'm sure that many people probably missed their seeing this topic today. And it is already been recorded. People can see this recording later also. But the sensitivity, specificity, and these predictive values are being very often used in our clinical practice. Anything you want to practice as a, like primary open-angle glaucoma, if you want to see the drugs or what are the tests, like fundus photography, fields, or velocity, whatever you are doing, it all depends on these values. So it is, we all need to have some idea about the sensitivity, specificity, and the predictive values. I feel it is not only for the institutional practitioners where they do the research, but I feel it is important for the postgraduates, fellows, and also the regular clinicians who are practicing whatever it is, like retina, glaucoma, or whatever the specialty they practice. So Rajul has given some examples on glaucoma and diabetic retinopathy, but of course this can be applied to many other diseases as well. So can you just give the few take-home messages for the today's audience, Rajul? Practical take-home messages on the sensitivity, specificity, and the predictive values, where they can really use it in the glaucoma practice.
So for everyone, we published this both article in IGO way back 2008 and 9. So you can read it where we have one article on sensitivity, specificity, predictive value, and other article on likelihood ratio. As Satyan was talking about, sensitivity, specificity is very important. And you can use spleen and snout for individual cases. And likelihood ratio, of course, not in every patient, but when you have a doubtful cases, you can use this along with your test to label the patient glaucoma or go back on the left side that patient doesn't have, where your disc is suspicious but large, and you have a doubt that patient really has glaucoma. Pressure is only 21. So borderline, every borderline scenario where testing would help. So this is very important, not only for the postgraduate, for ophthalmology itself, to use this in day-to-day practice, because we do perimetry OCT without understanding that how this diagnostic accuracy has been calculated.
Yeah,
So I would recommend
that's where I
reading
was trying to emphasize, Rajul. When we are doing either the visual fields or the OCT, it is not that when it is all 100%.
Yes.
So we need to understand every machine's limitations by looking at the sensitivities and specificities. I think that is where it really helps everyone us to understand it has its own limitations.
I still remember when we first published OCT in early glaucoma, definite field defect, and the sensitivity was 85%. And quite a few people came and said that, "Nee, nee, these are definite glaucoma. How can OCT miss?" So, because people don't realize that every machine can miss even definite glaucoma.
Yeah,
So,
not
very
only those
important.
days,
So
even
one,
today, the OCTs and visual fields can definitely miss out.
Yes.
Yeah, quite a good number of the so-called glaucomatous eyes.
one
So,
quick addition, Dr. Satyan.
yeah,
I think
please.
what Dr. Rajul told about all these tests is provided if they are reliable. That is the
Absolutely.
very important thing. If that is
So,
not reliable, it is not counted at all in the sensitivity, specificity, etc.
Point very well noted, and I feel it is so important to understand
yeah.
that of it. Otherwise,
Yes.
everything is in a mess.
And reliability, we are
Must-
going to take in some other time, the talk.
We will. And Rajul, if you don't mind sharing that article, and if the AJO permits us to free circulate, we
No,
will.
IGO, no? IGO, I mean IGO will publish.
Sorry, IJO. Sorry, I
IGO. It
just
will
said
we
AJO,
can
but it is
because
IJO.
it's a free journal.
Free
Open
journal, I know
access.
that, but we will
I
circulate
will
to all the
I will send you.
members.
I will
Yeah,
send you
we
the
will
PDF.
circulate it to all the members for sure.
I'll do that.
Yeah, as the time is at 9 now, we will close the session. Thank you so much, each one of you for your wonderful contribution today with the academic feast, and we will see you soon in the next month. And we are going to start soon a new program called the Man and the Machine, wherein we have a lot more about the machines, about their hardware, about their software, and how best we can use the machines. We will soon have that program starting from next month onwards. But we will keep continuing the journal club. So once again, thank you all for your presence today. Thank you again and good night.
Good
Thank
night.
you, sir.
Thank you.
Thank you.
Night all.